Post-inflammatory hypopigmentation. Definition. Post-inflammatory hypopigmentation is the result of melanocyte destruction or suppressed melanin production secondary to inflammation of the skin. It appears as a hypopigmented or, in severe cases, a depigmented macule. The inflammation may be due to physical trauma, a chemical agent, or a primary inflammatory skin disease. Causes of post-inflammatory hypopigmentation. 1. Physical trauma. 2. Chemicals. 3. Inflammatory skin diseases. Post-inflammatory hypopigmentation. White macules on scalp secondary to burned out discoid lupus erythematosus. Incidence. Inflammation-induced white spots are common incidental findings. Occasionally, they are the patient's primary complaint. History. The inflammatory event responsible for the white spots is almost always remembered by the patient. Physical agents that may induce white spots include exirradiation, frostbite, intralesional triamcinolone injections, and skin resurfacing lasers. Industrial exposure to chemicals such as phenolic and sulfhydryl compounds can also produce hypopigmentation. Some inflammatory skin diseases can leave residual hypopigmentation. Common examples are discoid lupus erythematosus, psoriasis, and dermatitis, particularly atopic dermatitis and seborrheic dermatitis in a darker-skinned individual. Uncommon causes are cutaneous sarcoidosis and mycosis fungoides, MF, a form of cutaneous T-cell lymphoma. Post-inflammatory hypopigmentation, irregular white patch surrounding a hypertrophic scar after intralesional triamcinolone leaked into surrounding skin. Note the scar is also hypopigmented. Physical examination. Whitish macules, no scale, or patches, with scale, conform to areas of prior inflammation. In the case of intralesional triamcinolone injection, medication can spread into the surrounding skin, causing hypopigmentation outside the original lesion. Post-inflammatory hypopigmentation, subtle white patches secondary to seborrheic dermatitis, more commonly seen in darker-skinned individuals. Note characteristic nasolabial involvement. Differential diagnosis. Post-inflammatory hypopigmentation may be confused with vitiligo, particularly when hypopigmentation is profound. However, the pigment loss is rarely complete, as it is in vitiligo. Moreover, in vitiligo, the depigmentation is only rarely preceded by recognizable inflammation. It is important to determine the cause of post-inflammatory diagnosis, ruling out inflammatory conditions, like atopic dermatitis or psoriasis, and neoplastic conditions, like cutaneous T-cell lymphoma. Differential diagnosis of post-inflammatory hypopigmentation. Vitiligo. Determine primary skin condition. Inflammatory, example, atopic dermatitis. Neoplastic, example, cutaneous T-cell lymphoma. Post-inflammatory hypopigmentation. Hypopigmented patches and plaques in a patient with cutaneous T-cell lymphoma. Laboratory and biopsy. No specific laboratory test is available. The biopsy is not specific, showing decreased pigmentation in the epidermis and occasional mild residual inflammation in the dermis. Post-inflammatory hypopigmentation. Epidermis, hypopigmented. Dermis, may show some residual inflammation. Therapy. Treatment is not usually required. No effective agent for repigmenting skin is available. Cosmetically troublesome areas can be disguised with opaque cosmetics such as dermablend and covermark. To avoid future hypopigmentation, patients are advised to avoid contact with any responsible physical or chemical agents and to treat primary skin disease promptly. Course and complications. Usually, pigmentation returns gradually. Patients need to understand that this process takes months, and sometimes longer. However, if the damage has been severe, the hypopigmentation may be permanent. Key points. 1. Inflammation suppresses or destroys melanocytes. 2. Characterized by white macules with or without scale. 3. Repigmentation, if it occurs, takes months to years.
Clinical case. A 14-year-old boy presents to the dermatology clinic with several light-colored patches on his cheeks and forehead that have gradually appeared over the past 3 months. His mother reports that the lesions developed after an episode of itchy, red eczema, which improved with intermittent use of a topical corticosteroid. The patient denies pain, scaling, numbness, or loss of sensation. He has no history of similar lesions or autoimmune disease. On examination, there are multiple ill-defined, hypopigmented macules and patches on the face. The surface is smooth with minimal residual fine scaling. There is no complete depigmentation. Hair within the lesions retains its normal color. Sensation is intact. A Woods lamp examination shows minimal accentuation of the lesions without bright chalk white fluorescence. What is the most likely diagnosis? A. Vitiligo. B. Pityriasis versicolor. C. Post-inflammatory hypopigmentation. D. Indeterminate leprosy. E. Pityriasis alba. Correct answer. C. Post-inflammatory hypopigmentation. Explanation. Post-inflammatory hypopigmentation, PIH, results from a temporary reduction in melanin production or melanocyte function following cutaneous inflammation. Common preceding conditions include eczema, psoriasis, burns, infections, and inflammatory dermatoses. The pigment loss is usually incomplete, and lesions correspond to sites of previous inflammation. Features supporting the diagnosis. History of preceding eczema. Ill-defined hypopigmented, not depigmented, patches. Normal sensation. Normal hair pigmentation. No chalk white fluorescence under Woods lamp. Gradual spontaneous repigmentation over weeks to months. Why the other options are incorrect. A. Vitiligo. Produces sharply demarcated, completely depigmented macules. Woods lamp shows bright chalk white enhancement. Leukotrichia may be present. B. Pityriasis versicolor. Usually affects the trunk, neck, and upper arms. Fine scaling is prominent and potassium hydroxide examination reveals hyphae and yeast, spaghetti and meatballs. D. Indeterminate leprosy. Typically presents with one or a few hypopigmented patches accompanied by diminished sensation. Peripheral nerve involvement may develop. E. Pityriasis alba. A common cause of facial hypopigmentation in children, often considered a mild form of eczema. Although it may resemble PIH, pityriasis alba is a distinct clinical entity characterized by recurrent, mildly scaly facial patches rather than residual pigment loss following a clearly documented inflammatory eruption. Key learning point. When evaluating hypopigmented lesions, a history of preceding inflammation is the most important clue to post-inflammatory hypopigmentation. Differentiation from vitiligo, fungal infection, and leprosy relies on the clinical history, lesion morphology, sensory examination, Woods lamp findings, and selected laboratory tests, example, KOH preparation when indicated.